Ah, amen.
Okay. And actually, let's also turn your.
Yes.
Okay.
Okay. All right.
World's highest level tech support.
Exactly, exactly. Okay, we're going to start. As you know, the topic of this discussion is race and health. And we have a special guest here from, okay, unmute your microphone if you want to speak. Okay.
How about this?
Oh, no.
No.
Ignore that. Okay.
Don't touch your computer.
Okay.
Yeah. Yeah. All right. People can hear you, don't worry.
All right, I get you. Okay. All right, we have a special guest here now, Daniel Cressy, who is the first person in the Gulf South to be functionally cured of sickle cell disease through gene editing. And he has co-founded an organization called Privileged Pilots, formed by two aspiring aviators who must overcome sickle cell disease in order to pursue their dream of becoming a licensed pilot. So I want to welcome Daniel, say hey, and I would like him to just tell us his story, this remarkable story of how you couldn't become a pilot until you got the sickle cell issue straightened out and how it was. So the floor is yours, Daniel. Please tell us and welcome.
Hey, Richard, thank you for having me. So this is a long story, but I'll try to cut it to where it's relevant to aviation. So I'm 23 years old, and I started flying at 19. That's when I took my first flight lesson, and everything was fine up until the point where I had to take my private check ride in 2023. And the issue was I had my medical certificate revoked, essentially, in which the FAA deemed that my disease, sickle cell anemia, was essentially a risk for aviation. And so with that, I had to kind of like navigate a solution, and there was no information online. There was nothing that the FAA was really telling me. And so I kept asking. I tried and tried and I tried until I was tired. And then I eventually realized that the FAA isn't budging. And so that's when I kind of took it up to like a civil case. And I inquired with Senator Bill Cassidy in Louisiana, and I used his office to make an official inquiry to the FAA to see what solutions were there for sickle cell patients. And so essentially, after his office made an inquiry, they actually finally gave me an answer. And that answer was to obtain stem cell transplant via gene therapy, which ironically enough wasn't even FDA approved at the time. But a few months later, it did eventually get approved. And then I was essentially the first one in line to get gene therapy in Louisiana because I told my doctors I was interested in it before it was even advertised, essentially. And basically, long story short, I eventually got gene therapy. It took me from 2024 January all the way till March 2026 to actually get cured. From the time that I started the whole process to the time I actually got cured was about 2 years and 4 months. And it was a long journey, a very difficult journey, but we finally did it. And I made history as the first person in Louisiana to become cured or functionally cured of sickle cell disease. And now I'm on the next steps of applying for my medical certificate this week and eventually get my medical, start flying, and become a commercial pilot. And so I created this nonprofit organization, Privileged Pilots, to spread awareness on sickle cell disease, but now also to educate and give back to the community and inspire other people, and hope that others can also receive this therapy because I know how difficult the process was.
All right, thank you. For those who don't know, tell us why this is so remarkable and how you feel about all this now.
So this is very important because most people with sickle cell live their lives in and out the hospital constantly. For me, I learned how to manage my disease very well at around 15 to 16 years old. And so I didn't have that many complications, honestly. But the great thing is most people in the future will be able to get this, but as of right now, it's pretty difficult. This cure uses your own cells. And so before you had to have a donor in order to even be viable for a cure via a bone marrow transplant. But with gene therapy, you don't need to rely on anybody else. The only thing you have to overcome is getting through the insurance hurdles, which is difficult, I must admit. But once you're through those hurdles, you're kind of independent. You're using your own stem cells. Um, and once you get the therapy, your blood is making pretty much normal blood. You can function like a normal person. Not that sickle cell patients can't do normal things, but there are some things that you're kind of restricted to, especially like cardio intensive activities or eating certain foods can lead to pain crises, or sudden change in weather can lead to pain crises. So this cure is now going to allow people to live a normal life, patients to live a normal life. And I think that's amazing, because we don't know what normal is. We live with this disease our whole life where our body is constantly trying to fight something, seems like. And so now we're going to be able to live a normal life and raise a family, keep a job. And these are issues that I was told from other patients. Thankfully, I didn't face these issues as much, but it is life changing because it improves the quality of life.
All right, thank you. Do you happen to know if the sickle cell funding is adequate for others so that others don't have to go through this?
No, it's not. To keep it straight, there are many barriers for patients, namely location. To put it in perspective, Manning Family Children's in New Orleans is the only place in the Gulf Coast that offers this treatment. And there are sickle cell patients everywhere, not only New Orleans. And so when you just think about that one factor, not even including other factors such as appointments, insurance, qualification for the cure, it's a lot of things that still needs to be resolved so that other patients can receive this therapy.
All right, thank you. Okay, we have time for just one question here before we have to move on to somebody else, but we want you to hang around, Daniel. Anybody got any questions for Daniel?
I was kind of wondering, how do you feel now, and are you hopeful that this is a treatment that other people, do you feel special, or do you feel as if this is a treatment that'll help a great many other people?
How do I feel now physically, or how do I feel now as it relates to that question?
Yeah, how do you feel now physically? Yeah. Like
Oh, I feel
how's your current state different than the way you felt before the gene therapy?
So I feel great. I know that I have much more sustaining energy. I also recently joined a run club, so I'm able to run and walk for many miles now, which is something that I really couldn't do before. So I feel great. My blood counts are through the roof. My hemoglobin is amazing. It's kind of funny. My hemoglobin is actually higher than the average person right now. Even though I just got cured. So, you would think that an average person has a higher hemoglobin than me, but no, my hemoglobin is doing stellar and I feel great. So,
All right, so what is it that you want everybody to know out there, especially those who have money to invest in further cures?
um, well, I want everybody to know that there are organizations like mine who aim is to spread awareness on sickle cell and also help others receive this treatment. And so if anybody would like to go to our website, privilegedpilots.org, they can learn more information on supporting us. And even outside of our organization, there are many foundations or even just hospitals that could use resources to help patients with getting this treatment and just living a more satisfying life, having a better quality of life, especially as it pertains to obtaining a new treatment. And there's a lot of funding that needs to be put towards sickle cell research. It's a lot, and I can't even really like deep dive into it. But there's a lot of things that we still have to do as a community to ensure that everybody and every family has access to this treatment.
Right.
And I and I know that the other guy asked the question on do I feel special? Kind of relevant to what I'm saying right now. I do feel special, and I don't try to feel special, but I do feel special because I am currently the only person that got this treatment in Louisiana, and I don't wish that it's that way. I mean, things are so new, so things happen over time, but I want this to be something that's something that everybody can get, because I do get a lot of messages from patients through our website and our organization about what can I do to get this treatment? You know, I just had a pain crisis and I don't feel great. And it does hurt me a lot knowing that I'm only one person and I can't do much for them other than tell them what steps they can take. And so just supporting us and supporting any other sickle cell foundations is a great step.
All right, thank you very much. We've got some requests to make sure that put your website and a way to contact you in the chat if you can. And
Okay.
I'll also remind people that right here in Washington, there's the Center for Sickle Cell Disease at Howard University. Unfortunately, they didn't respond to my request to join us. And there's also a sickle cell organization, sickle cell, I forgot the name of it, a center that helps sickle cell research nationwide. So thank you, Daniel, and all the best to you.
Thank you.
Okay. All right, now we have a special guest here, special presentation. This is from the Main Street Media Cooperative, which is offering services to newsrooms around the country, providing reporters to work collaboratively on stories about the many ways the actions in Washington are affecting people and readers close to their homes: health, environment, immigration, criminal justice, the economy, etc. So Amanda Bennett and Susan Chira and Miranda Spivak are all here, I see. I don't know who wants to speak first, but the floor is yours to tell us more about this new initiative.
I wasn't sure if Amanda was able to join the meeting, so I'm looking through the gallery, and I think Miranda is here. It's always tricky, Amanda and Miranda. But,
okay.
But I'll plunge in, and if Miranda, you want to add anything? I see you now. Please. So essentially, and I think Amanda was having some trouble dialing in, so I'm not sure if she'll make it, but she wanted to make it. She wanted to make it. So basically, Amanda and I were kind of we were like other ends of the rope trying to figure out, as so many people are, what could we do at this stage of our lives to be helpful to local newsrooms, whose role has become ever more vital, even as its economic model, as everyone knows, has been under such challenge. And so during my time at the Marshall Project, I had the privilege of addressing this group one time. Richard kindly asked me my Marshall Project role.
Yeah, Susan, tell us some of the other things you've done to get to this point.
Sure. Okay. So I was at the New York Times for almost 40 years, a variety of roles. I was the international editor, and I worked closely with Dean Baquet on his team, overseeing like daily news. And then I left the Times after a very happy time there, and because I had the opportunity to become the editor-in-chief of the Marshall Project, which, as you know, is dedicated to criminal justice and looking at the inequities and abuses in the system. And so after I left the Marshall Project, I was trying to figure out, during our 6 years, my 6 years at the Marshall Project, I had worked with countless local newsrooms and gotten a really good sense of how extraordinary people are, but what they're laboring under. We would do collaborations and people would like, well, this week we can't answer email because we're all on furlough this week, but next week we can answer email, or do you think you Marshall Project people could let us have a data analyst for a week so we could crunch these numbers or whatever? And so I thought, is there a way that we could take that? And Amanda was at the same time talking to the Partnership for Public Service. And this was at the beginning of the Trump 2 term where the mass layoffs of civil servants were starting. And the guy that Amanda was talking to at the partnership kind of said, oh, I was talking to him, Amanda was talking to him. He made the match and we put our heads together. And what we ended up coming up with, which Miranda has kindly joined us, is we knew a lot of people at, to be honest, our stage of life. Like they weren't necessarily working full time, but they didn't want to stop being involved. And so we started reaching out to our networks of journalists and saying, listen, would you be willing to essentially donate your service, or for a very modest honorarium, which we pay, not the local newsroom, work with a local newsroom? But we wanted to have our scope. We felt that one of the real challenges for local papers or outlets, because many of them are digital, is to really understand, as the Trump term started with this avalanche of changes and has continued, it's really, a lot of these things are specialist policies, healthcare, immigration. There's a lot of fine print. There's all kinds of regulatory and other changes being made, even without legal changes. And so we thought, we'll gather people who have specialty expertise in various areas, and we'll either send them to a local newsroom to do a story under the supervision of the local editors, or have them work collaboratively with a reporter from the local newsroom. And so we're starting it. We've been at it over a year. It's slow and steady. And I know Gary Lee is on this call, and I'm giving you a virtual wave, Gary, because we're both friends and trying to pull off a collaboration. So he can talk about that. But the idea is that we find out what a local newsroom wants to cover, as long as it's in that window of, look, there was a change in the tax code that affected immigrants. How's that affecting my local community? The Medicaid cuts, what does that mean if you live in a particular state or locality? We're working with Ron Smith, whom many of you probably know right now, and he's interested in exploring what the holes in the safety net mean for 3 different communities in Wisconsin that are part of his network. So what we basically do is, our only kind of limits are that the local newsroom has to have libel insurance, because we want to make sure that any journalists involved in our collective are protected during the duration of the work they do for the newsroom. So they need to have libel insurance, and then they need to sign a contract with one of our journalists, and that puts them under their paper's local libel insurance. Even if no money changes hands, you're still covered if you signed a contract, because you become an official contractor. This took, by the way, 5 months of talking to libel lawyers and other lawyers to figure out, but so we protect them from libel and we offer them up. And Miranda has joined us, and I'm going to, kick the ball to her, because we also have spun up a project about elections. And because there are so many changes, right, to polling places, security. Miranda will elaborate, but so she, who has so much expertise in decoding local government and has herself worked both nationally for the Washington Post and locally a lot of places, and has helped us. The other thing we're doing is we're beginning to prepare kind of cheat sheets where we take some of our experts and we have them go through, like, what are some of the changes in healthcare, immigration, data security, et cetera, that are likely to affect your locality. And what are some of the national sources and Washington sources that you might need? Because again, as you all know, people can't afford to have Washington bureaus. People can't afford even often to have state bureaus. So they need that link to people who might have sources. So we're trying to kind of fill those gaps and make it at no charge to a local newsroom. So over to Miranda.
Okay,
Thanks.
briefly, Miranda.
Yes, very brief.
Okay.
I am trying to spearhead sort of the political stories. And just to add to what Susan said, obviously some of that can be, SNAP, healthcare, Medicare, Medicaid, whatever changes are emanating from DC. But also I'm looking at election security, how communities are trying to assure the public that their elections are going to be free, fair, and open and accurate. And so we've matched up, in that case, we've matched up a reporter who's based in LA, but he's working for New Mexico in depth, which was very interested in election security. But, there are a lot of different ways to go about it. And the only other thing I would add to what Susan said is that we are looking for, more local newsrooms, but we're also looking for more experts. And
Yes,
among the people on this call who I've been on for several years, I know there are many experts out there. If you are able to, we're not asking you to totally contribute your time, but you're not going to make a lot of money off of this. But if there is some issue where you feel like you could help a local newsroom, we'd like to match you up with that.
Right.
And that's pretty much it. And thank you, Richard, for letting us do this at this moment. Because I know, I know you've got a great program planned, and Susan had some commitments, and so did Amanda. So thanks. Anyway, get in touch with us. We can drop our emails in the chat.
Right.
We're also, we've had trouble with email only because some people just don't have time to go after it. So if you want to connect us by cell phone too, we can text or WhatsApp or whatever. So that's pretty much it. But again, thanks, Richard, for letting us.
Thank you so much.
Thank you.
And I would just say, we are also happy to send more details about what we do. We have a kind of info packet that's easy to send if you're interested, but we just appreciate your hearing us out. And if anyone is interested, reach out to us at any time by any way that works. Thank you guys so much.
Thanks.
Thank you. And you've got a shout out to you from Mary Curtis to Susan in the chat room.
Thank you, Mary. Hi, Mary. That's lovely.
Okay, hold on.
Michelle, of course I remember you. Now I'm looking at the chat. Michelle, it's so nice to catch up with you for sure. Okay, lovely to see old friends.
All right.
Take
Moving
care,
right along.
And Richard, do invite us back just to listen. Anytime.
You're invited back anytime.
Thank you
you're
so
always,
much.
always invited. Okay.
Take good
All
care. Bye now.
All right, bye. I want to shout out here our next presenter here, Nicole Carr, investigative journalist, and this is her book, The Price of Exclusion, The Pursuit of Healthcare in a Segregated Nation, which sort of sets the tone for a lot of our discussion to come. She was actually in town here at our last roundtable, but she was at the Martin Luther King Library, which at the same time, so we're glad that she was able to come back. She's on a book tour now, so we're glad that she could make time today. So take it away, Nicole, for your 3 minutes about what you have to say that fits into this overall topic of race and health.
Sure. Thank you, Richard, for having me. And thank you. And thank you to all the other authors in the chat who are posting their very important work. The Price of Exclusion has only been out about 3 weeks now. The idea for the book came in 2020. I was working in local television in Atlanta and had the 3 kids, 4 months postpartum. With our third, came off set one night after the 11 o'clock and started thinking about how we got through this 100 years ago. And so I had an ancestor, great-grandfather who was a physician who I began researching. His story led me down a rabbit hole where I saw parallels between the health of our nation in racial reckoning and democracy, in a fight for human and civil rights. And thanks to Howard University and a new archive they had digitized with the Mellon Foundation grant, I was able to track him and track his story and use his narrative as a through line to take us through more than a century of medical histories through the lens of lesser known Black physicians. I like to talk about the extraordinary and the ordinary. And so it takes us from America's, current day rural Georgia, Hancock County, Georgia, where there has not been a hospital for 2 decades, functioning hospital, a single high Black population, a single Black physician who went to Spelman and Meharry, who is practicing out of the home that her grandfather, uncle, and father practiced out of. In using this third generation Meharry graduate to kind of set the scene and what rural healthcare is looking like and how Black people are holding each other down in rural America through these issues. 100 years ago, they had a thriving healthcare system that they no longer have. And then it takes us to America's first 4-year medical school. The first chapter is the medical education of the Negro sets the standard. The first 4-year medical school in the entire country was at Shaw University. It is a casualty of, for those familiar with the Flexner Report, and the report that shut down most of our Black medical schools except for Howard and Meharry in the early 20th century. And an archive that I got my hands on where I was the third person to see it. It had the founding paperwork for the medical school. And the language economy in the archives will help us to relate some issues of years past to the current day anti-everything movement. And we see some similarities in the issues that impact the education of physicians that will now impact us for generations to come. How we got to the position we're in today and how this will continue given the current policies. It takes us to America's first public hospital in the United States and the kind of romantic story that the state of Georgia tells about its founding versus what we know from the archives and how the idea of the public hospital is essentially an insurance policy for an enslaver. And now you don't have to keep sick property on your property. I start thinking about what the hospital represents in terms of the enslaved and dying one of 2 deaths. Either you are nursing me back to health so I can go back to the plantation and labor until I die, or I come here to die. And so this idea of hospital distrust, what does that look like? And then some medical school students I was following in current day, and of course my great-grandfather's story.
Let me interrupt you. I got a question for
sure.
you. I was talking to a friend, Derek Jackson. Many of you may know him. He's a columnist in Boston. His wife is a physician as well, named Michelle Holmes. She wrote a commentary in 1989 with 2 Black colleagues commending and criticizing a paper in the New England Journal of Medicine authored by white researchers who noted the racial disparities in the use of procedures to treat heart disease. The study noted racial disparities without really asking why the disparities exist. This is Derek talking. My wife and her colleagues wrote, the most likely reason for these inequalities is that physicians value Black lives less than white lives. Do you agree with that?
I do, and to talk about medical journals, one of the most interesting archives is it's an article in the New York Medical Journal from late 19th century that speaks of the problem of the negress. And this esteemed Alabama doctor, whose history is told a certain way today, writes about how the negress is his most problematic patient. She exaggerates her pain during labor. The elder negress, she practices a sort of what he's essentially saying is a sort of voodoo. She believes there's nutrition in the placenta and that they ought consume it. And I just laughed because I was like, isn't this something in Good Housekeeping magazine about putting stuff in your shakes like today? And how he's surprised that he doesn't see more cases of ovarian cancer in the negress because of how promiscuous she is and how she uses the organ. And these journals, why is that important today? We're still extracting some of this expertise out of curricula and textbooks today that set the standard for physicians at your Johns Hopkins, your Yale, your Harvards, while you had these black physicians who were training in our own institutions, combating that research, but also members of the NMA, the National Medical Association. I had an editor ask, well, why was it important for them to be a part of the AMA? Well, the AMA helps set policy. It's a research standard. And so the exclusion of black physicians in these systems matter to the way that we've understood our bodies, the health of our nation, how socioeconomic conditions play into that. The stress of being black, I'll be black in every lifetime, don't want to be anything else, but the stress of being black that is embedded in your body because of the risk that you calculate every day just to survive. And so I thought it was important to talk about what the physicians were going through and why you're sitting at this 5% today. We talk about a lot of statistics, and we don't have this many enough black physicians, and the AMA comes around while I'm reporting during COVID, and they're apologizing for the role they've played in the Flexner report and shutting these institutions down. But what does that mean? Well, it means that we're operating at levels we were a century ago. Now you put these exclusionary policies in place today, whether they're economic policies, the DOJ going after these medical schools for folks who have already been admitted, challenging the place. By the way, the idea...
Let me underscore that. The DOJ is going after medical schools, saying that they practice too much DEI at a time when, you know, the percentage of black doctors is way below the percentage in the population.
Yeah.
All right, go ahead.
Well, and when you go into, speaking of that language economy in the archives, you say, well, why did four-year medical education begin? Johns Hopkins, at the time, you know, we're talking like the 1870s, they're toying with the idea of expanding from a rigorous 3-year program to a 4-year medical school, but that's called innovation. When it comes to beginning to put more black men and women in white coats in America, they say, well, if the Negro is to become a doctor, make him or her go to school longer. Make them choose or prove himself as intellectual as the white man, make them prove their merits, make all of these little key words that you hear today as you're toying with these very dangerous policies that will place us, that have already put us under, because we will feel the impact of what's happening now. You know, my grandchildren will feel it. It's already, the damage has already been done, and there's so much chaos in the moment, it's hard to begin to calculate what we're doing now. It's the same type of chaos, same playbook, same stage play, different players, that will have us asking ourselves generations from now, why are we here? And so the statistics aren't enough. I think the narrative is enough. I never considered myself a healthcare reporter. I've reported a lot on race and democracy. And I say, well, what gives me the permission to be the vessel by which the story is told? And so I allowed an ancestor to give me the permission to usher the story in. And so that's the book.
Okay, thank you. Dr. Benjamin is next. He's the CEO of the American Public Health Association. In fact, I asked you about this. There was a posting on Facebook. I'm trying to find it now, in which somebody said that there was a survey of white doctors. I think I asked you about this, in which most of them believed that black skin is thicker than white skin, and therefore the remedies that work with whites don't work with blacks. And I asked you if you'd heard that as well. So.
You know, there are lots of myths in medicine, and yes. There are lots of myths in medicine, and tragically, you know, we all took physiology, we all did anatomy, we all took scalpels and went into cadavers and actually looked at skin. You know, you actually go in and you take off skin and you look at it under the microscope. So there's no intellectual reason why you should actually think that one race of people's skin, I recognize that's a social construct, is any different than any other. Or that we do the study of neurology and pain. We all studied the same material, but it's, unless somebody specifically tells you these stupid things are stupid. They're obviously wrong, but people do integrate them in their thinking. Now, and we also sometimes taught things that aren't right. You know, regardless of race, a woman who comes into when I was training in internal medicine with chest pain, was less likely to be perceived as having a heart attack, even if she had high risk factors, because women couldn't possibly be type A personality. Didn't matter whether she had hypertension, diabetes, or any of the other hyperlipidemia, any of the other risk factors for cardiovascular disease. Her pain was psychological or in her belly or something else. She got an EKG at some point, and we said we had an oh shit moment. But if you were a male, black or white, with the same symptomatology, the same age, because we thought that women's hormones protected them. And the truth of the matter was, the evidence and science had not been done. I mean, it makes no sense, right? But medicine has lots of myths. Medicine is an art and a science. And tragically, far too often, the art piece is subject to myths. So that's absolutely one I heard. I heard that from colleagues when I was in medical school. People who I would never let touch me. Yeah.
I hear you. Okay. All right. Anything else you want to add before we move on to the next person?
Yeah. Let me just say, I want to pick up on Daniel's thing.
Yes.
Those of you reporters in the room, I guess there are a few of you anyway, right?
A number of us, yes.
If you want to do the story of health equity in this country, it is sickle cell anemia. Right now, my bias is that I got into medicine because I was interested in sickle cell research, but it goes back to the fact that a lot of money was thrown into sickle cell research. We built sickle cell centers, and then eventually the money went away. But you're now looking at a disease. It's kind of like the history of HIV/AIDS. We're looking at a disease that crippled individuals. I mean, Daniel living this long is the benefit of enormous medical research and intervention over the years and things we learned from that work. And this gene therapy that he has is the future of medicine.
All right.
Okay. And so the question here is that going to be available to anybody for any disease? Because we're going to be talking about going into people's genomes and addressing them early for cardiovascular disease, for cancer, for hyperlipidemia, for diabetes. I mean, we're at a place. There are a lot of ethical issues here. Costs, expense, access to care, training, having enough people trained to do this.
Wait, what are the ethical issues? Are those the ethical issues?
Ethical issues about going in and screwing around with your genome.
Oh, okay.
You know, deciding what babies are going to be born tomorrow because of we've now done genetic screening and we're going to pick this baby over that baby, this embryo over that embryo, this baby who's going to look like me over this baby who doesn't look like me. Okay, so this is an interesting process we go forward. But this story of sickle cell is a phenomenal one, and I remind you that the military. I mean, what was fascinating when I heard he wanted to be a commercial pilot. Because the question will be not whether or not he's now cured. The question will be, does he have enough in-organ damage that he can now pass a flight physical to fly commercially? He might be able to pass a flight physical to fly a private plane, but he may or may not be able to pass a flight physical if he has enough kidney damage or eye damage or whatever over his years. We'll see. I wish him well. But just, and hope for that. But just know in the military, even having sickle cell trait, there was an effort to keep, in fact, at one point, black flyers could not fly if you had sickle cell trait, meaning you didn't have the disease, but you know, one of your genes was a sickle gene and the other gene was a normal hemoglobin gene. And by the way, I have trait. And yeah, people with trait might die suddenly if exerted, particularly if you get dehydrated. I don't scuba dive, and I wouldn't fly in an unpressurized craft because of that, because there are risks. But they wanted to keep as a way of keeping blacks from flying. Another way to keep them out of the place, out of airplanes in the military, was if you had trait. And it was a big fight in the military, which ultimately was won by black flyers to allow them with trait to fly. And even though there wasn't really a scientific study done, but there were many Tuskegee Airmen who weren't screened, who would often complain about having left flank pain, probably splenic infarctions, who had trait, who flew marvelously, as we know. And so the point is that even having trait, if used inappropriately from a policy perspective, can undermine our ability for us to succeed and to go into different disciplines and jobs. So it's an excellent story around health equity, et cetera. And I can talk about Trump later and what they've been doing.
All right, we'll talk about Trump
But
later.
I just think that's when I heard his story,
Yes.
it's a fascinating story. And I encourage some of you folks to write about that, because I think that's a wonderful story about health equity. And then if you line that along all the stuff we did or didn't do with HIV/AIDS,
Yes.
those two stories align.
All right, thank you. That's good. Delise is next. Deputy Health Editor at Politico, Delise Smith-Barrow.
Hi everyone. Like Richard said, I'm Delise. I'm a Deputy Health Editor at Politico. And I've been in that role for about a year, but I've been covering health in and out for probably the entirety of my career. When I was a very young baby journalist, I was writing some about consumer health. So this is, kind of basic stuff, like biking programs that were introduced to get people to, to move more, gardening, getting kids into eating healthier foods, things like that. But in my role now, I am helping oversee a team that looks at healthcare policy as it's created and shaped in Washington, D.C., and oftentimes healthcare access. So we talk a lot about not only the changes to Medicare and Medicaid and Obamacare, but how does it affect someone? So right now, because of changes with the Affordable Care Act, a lot of people who were once using Obamacare for their health needs, now it is just out of reach. They cannot afford it. Their premiums have skyrocketed, and we are looking at the ripple effect. Like, what does that mean? And we're already seeing that for some it just means I'm just not going to have health care. And we know that a lot of the people who are making that decision are people who don't have a lot of money, and they're often black or brown. So when I'm talking to my reporters or even my students, I teach health reporting at Georgetown University, so not too far away. I tell them that almost every health story, whether it's consumer health, the business of health, health policy, health law, it always goes back to who has access to it, who doesn't. And we've seen story after story after story about how often black people don't have enough access, don't have the right access. The maternal health crisis where black mothers aren't being listened to, aren't being believed when they're giving birth. So, whether I'm guiding a reporter or a student, I try to push them to think about, okay, this is the policy, but who is it going to affect? How many, millions of people are being kicked off of their coverage, or saying, I simply can't afford the coverage, I would love to keep it. That's not realistic. And so, I think that's explored through Nicole's book, which I've read and enjoyed. I think we've seen it explored in a lot of different ways. And I think the hard part for journalists can be figuring out how do we tell those stories in a way that's nuanced and really gets people engaged. Like sometimes with health, once you get into the Medicare versus Medicaid, their eyes glaze over, they don't know the difference, and it just does not feel relatable. It does not feel attainable. Even when there's open enrollment, how many of us see that 50-page packet and say, just sign me up to whatever's easiest? Can I auto-enroll with the thing I had last year? It can be really intimidating. And so I hope that in my work as a journalist, I make healthcare, health language, less intimidating, and people are starting to get even an inkling of, okay, this is what I need to know to advocate for myself or my family members.
Okay. Thank you, thank you, thank you. That was my, oh, here it is. Okay. Okay. Oh, thank you. Okay. All right, thanks. For those in the room, I wanted to remind people that we do have the bottled water, and we have some salads and chicken out there if you want to munch while you were having the meeting. Just go right ahead. Next, we were going to have from the on the Zoom, Dr. Shardana Lawrence, who is a senior manager of JED Greek Letter Organizations Programming. What she has done is her organization has partnered with the Alpha Phi Alpha fraternity to deal with mental health issues among their members to be sure they don't get them, or if they do have them, they're treated. And an alarming fact leaped out at me as I was looking into this, that black men commit suicide at higher rates than white men. And something needs to be addressed there. So I'm going to call on Dr. Donna Lawrence, who is here now. She's down in Huntsville, Alabama. Welcome and talk to us.
Awesome. Well, thank you so much, Richard, for having us. And I do have my colleague too, Justin's online. So Justin, you feel free to chime in if ever you need to. But it's so great to greet you all from the great state of Alabama. We had some weather out of Atlanta, so I wasn't able to join you in person. But, just to kind of build upon that point, we're actually seeing an increase in suicide and suicide ideation in the Black community across men and women. And we're seeing an even higher percentage in suicide in Black men ages 20 to 24. And so just to kind of give you all like an overview of the JED Foundation, our mission is to protect the emotional health and prevent suicide for teens and young adults. So we have quite a few programs that get at those different communities. The community that I specifically support are fraternity and sorority organizations. So most of you have probably heard of the NPHC or the Divine Nine, historically Black fraternities and sororities. All of those are within the NPHC. Now, we do support all fraternities and sororities. So we have clients that are across the spectrum of different types of organizations. And we do—
tell us what NPHC is for those who don't know.
For sure, for sure. NPHC stands for National Panhellenic Council. And so that's a formal or official name for the Divine Nine. Thank you for calling me in on that. So we do have different councils or different groups that we work with across the spectrum of fraternity and sorority membership. And, a lot of folks may ask okay, so what's the point? Why would, the JED Foundation specifically focus on fraternity and sorority organizations? And the truth is, the proof's kind of in the pudding. And what I mean by that is that every fraternity and sorority that exists, I don't care if they're a majority white fraternities or sororities, majority Black fraternities or sororities, all of them were formed for this purpose of creating community. And most of them were formed out of exclusion from other organizations. Case in point, Alpha Phi Alpha Fraternity Incorporated, which was founded at Cornell, was created to provide a support system for Black men attending that particular university. They were not able to join the organizations, not just the fraternities, but really any of the organizations that were on campus. And so they created this lifeline, the support network for academic support, some cases financial support, social support. And so in that, JED recognizes that this is a protective factor, right? So when you have community that is inherent in your organization, that already creates a network that we are trying to build upon. So where the JED Foundation comes in is approaching these organizations from a systems-focused lens. How do we help you create an infrastructure in your organization that specifically supports your members? And so what we do is we have a few programs, but we have our technical assistance program. We have workshops that we help the organizations go through in order to build those supports. Again, focusing in on mental health promotion and suicide prevention. And so, when you think about if you think about like just your lifetime, or thinking about the conversation around mental health as you've grown up. I know in my household, it was, hey, keep that to yourself, or hey, that, we don't put our business in the streets, or those types of things. And obviously that is not working, right? Obviously that is causing some type of harm within the communities that specifically within Black and Brown communities. And I would even expand that to think about not just in our NPHC organizations, but we have a very diverse demographic of young adults that are joining fraternities and sororities that are not in NPHC, right? And so we also are helping these organizations that are our clients to understand that when you think about mental health, it has to be from from thinking about all of the different people that are joining your organization. It can't be a one size fits all model. And you have to be consistent with how you think about your policies. So, do you even have a policy that addresses postvention, which is when you come in or when there's a crisis that happens? It could be the death of one of your members via suicide, or it could be some other modality. I've had to deal with campus shootings and things of that nature. So, do you even have a process to support your membership? A lot of times, y'all, no is the answer. And so when you think about how death in and of itself can impact a community of people and there's no plan, that can cause even more trauma, right? So we come in and we help provide that support. But, I guess I want to just kind of wrap up and say that, one of the biggest things that I stress with our clients is thinking about the dynamic of membership. So, of course, we came in talking about suicide in particular impacting folks who are between the ages of 20 to 24, specifically men. However, thinking about race and how it means to operate within particular bodies within an organization. So if I'm talking with Alpha as an example, Alpha Phi Alpha Fraternity Incorporated, my conversation looks different for them than it may be with one of our other clients, right? And that's not to, call anybody out or be like, hey, you guys are doing it wrong, but we have to be conscious of the fact that when Black folks operate in a minority space within your organization, you need to be intentional in a particular way about providing mental health support. So, the JED Foundation is just trying to close gaps. We're so excited to just be a part of this conversation, and I also welcome any of your questions.
Okay, my question is, what is mental health support? What do you do?
Well, that's a big question, and to be as vague as possible, it depends. So, it could be different. So mental health support, again, it's dynamic. So if I'm talking to an organization, so headquarters, corporate office, staff, then mental health support may mean, hey, we need to create a partnership between you and some type of mental health provider, right? To get you all get your members resources that they may need for entering whatever the concerns may be. We've seen a lot of concerns around like sports betting, relationship violence, or just how to navigate a breakup. That's been a really big topic too, that some of our clients have talked about. However, if I'm on a singular campus working with a chapter of members, that looks different. 9 times out of 10, it's, hey, we need help with how to develop a peer network so that we can support each other. Because that's another trend that we're seeing, and that students don't want to come to the grown folks anymore for help. They go to each other more than they go to maybe even professionals. So if we can help them understand, hey, as a peer counselor, as a peer that's been trained in how to have a conversation around mental health, then they can be that gateway to encouraging their friends to seek professional services. So, like I said, very vague, but very broad, I would say.
Okay, thank you very much. All right, moving right along, we have right here in the conference room here, Dr. James Rogers, who is Director of Product and Food Safety Testing at Consumer Reports, who led its testing of braiding hair products. In 2025 and 2026, Consumer Reports released 2 investigations on braiding hair and found concerning levels of lead, carcinogens, and volatile organic compounds in nearly every product tested. So I'd like to have Dr. Rogers elaborate on that, and also to tell us what we should be concerned about and what we could be doing about this issue.
Yeah, thank you, and thank you for inviting me. I'm not a journalist. I'm a food and water microbiologist by training. Former Morgan State professor, former DOD microbiologist, former USDA microbiologist, and I've been with Consumer Reports for about 10 years. This project came to me when an original journalistic effort wanted testing. And although I'm a microbiologist, not a chemist, I took this on because I was invested in this for a couple of reasons. Number one, I have 2 adult daughters that wear these products, and I wanted to be able to give them advice as to what they might want to be concerned about with these products. The second reason is that if you look at the data, I've seen some numbers that Black women use about 18 personal care products where white women use about 11. Plus, those products tend to have more contaminants in them than mainstream products. So we have to be really, really aware of what we're putting on our bodies, and what goes on our bodies get in our bodies at times. And so those are the reasons why I took this project on. So what we did initially in the first study is we took 10 products, we tested it for volatile organic compounds such as acetone, benzene, etc., and then we also tested for heavy metals like lead and arsenic. Closer? Oh, okay. And so arsenic, cadmium, lead, etc. And what we found is that the majority of those products had something that had potential to harm the wearers of this product. We did a risk assessment where we tried to gauge what the actual exposure might be and what those levels might be. Got criticism, though, because they said our risk assessment was not very realistic. And so for the second testing, Black women asked us, well, what can we use? And so we tested those products labeled safe. We tested human hair. Human hair had orders of magnitude of lead in it, much more than any other product that we tested. And human hair is seen as an alternative to the synthetic products. The other concern is, well, how is this lead getting in there? And we believe that the women that sell their hair for the human hair market are exposed to lead in their environment, in their diet. And so that's something else to explore. We were also concerned about the braiders. The braiders actually are exposed to these products for days and hours and over years without any type of protection, not wearing masks, not wearing gloves, etc. And so we were really, really concerned about that. And in the second testing for the same targets, the same contaminants were detected, and as I mentioned, even more in human hair. So what we did is we took that information and we did a number of things. Number one is that we advocated for new rules at the federal level, but knowing this administration, that the FDA, which I'm familiar with, was probably not going to pass anything, we started working at the state. So there's the Beauty Justice Act in New York that we've been supporting, trying to get legislation passed where these products would be tested, would be reported on, and actually regulated. Unfortunately, it didn't pass earlier this year, but we're going to try again. We're going to support that. The other thing is that we did a lot of outreach and education to consumers about these products, but also what can they do to change things? We submitted a number of petitions. We submitted a number of acts toward the actual manufacturers. We actually showed up at their door and wanted to deliver the petitions to get these manufacturers to commit. Now, I do have to say there's some smaller manufacturers that are working with us to try to set limits, to try to be transparent in testing, to try to actually find good labs to help them test. Testing is expensive, but they're willing to do this, and they're usually black woman-owned manufacturers that are willing to commit to actually produce a much safer product. Also want to say that, you know, this resonated with the mainstream because we were nominated for an ASME and a Deadline Club awards. Didn't win, but at least we were nominated because we were recognized. And so in the future, we just recently published about hair dyes and hair dyes that resonate in the black community and Afro-Latina community. And we've actually stood up a brand new personal care product testing group where we can test more of these products. The black women asked us, please test wig glues. Please test wigs. Please test eyelash glues. There's a report that there may be formaldehyde in these glues. And so we want to do more testing, but it's all about resources and timing. So hoping that we get more publications and more information out there, but also more advocacy. We're going to get more traction at the state level than the fed level. So we're looking at California, Illinois, et cetera, as some other states that may be willing to work with us in getting some of these state level regulations put in place.
Is that how you expect to get more money to do this research?
Well, we're nonprofit, and so we run totally on donations, grants, memberships to Consumer Reports. One of the unfortunate things is not a lot of black people know about us, but we're trying. Our article was published in Ebony, Essence, online, et cetera. But yeah, we would welcome additional money to actually do more testing. So.
Where do you get this? Where do you get this money? Where could you get the money?
We actually have individual foundations that will fund some of our research. I've been successful the last couple of years of getting some funding for food safety and water safety. And we're just starting to try to find funding for this type of work too.
Maybe some black organizations could step up to the plate.
Would love to have it. I've been suggesting we reach out to the Divine Nine, et cetera. Churches, large churches, some of these mega churches may be willing to help us out. But yeah.
Okay. All right, thanks. Just one more question before we move to the next speaker. Anybody got a question? Okay, Yannick.
Yes, ma'am.
Oh, what? Introduce yourself first.
I'm Yannick Rice-Lamb. Thank you. Hi, I'm Yannick Rice-Lamb. I'm at Howard University, and I'm an independent journalist. Also work with fierceforblackwomen.com and other sites. One of the questions I had for you, have you done any testing on the hair that's made from banana leaves?
Yes.
And then
yes.
and the
Please
second
go to cr.org and find our article because the second round of testing was safer products, plant-based products, human hair, and then other synthetic products that were supposedly safer. So yes, we did test the plant-based. There were actually two products at that time.
We did something at hunewsservice.com about the when it first came out about this study and also the banana leaves and other synthetic things. I was distressed to hear about the human hair.
Yeah.
Because I usually have my hair braided in the summer.
Was the banana leaf safe? Is that safe? The banana leaf?
It was about the same as synthetic hair, and
yeah.
we believe that that's because of wherever they're growing the banana trees. You could have, for instance, arsenic or lead in the soil. It's taken up by the plant. It gets into the fibers and so on. So we've actually talked to Rebundle, which is one of the companies, and suggested that they explore other places to buy their banana fibers from where they're getting it now, or to test the soil. But again, testing's expensive, and you got to know what you're doing.
And the human hair, you said that's from the lead in the body of the person.
What we're suggesting, see, when you're exposed to lead, and you know the MDs can help me out here. When you're exposed to lead, it gets taken up in the body, and you can actually get it into your hair. And so that's where we think it's coming from. But none of the manufacturers responded to us about our queries. Why does your human hair have so much lead in it? So,
thank you.
Okay. All right. Go ahead. One more question.
Just really quickly, Yannick and I work together in a consortium, a journalism consortium, her from Howard and me from Morehouse and Spelman CAU. I would target campus media too. And so I'm going to take this back to our social justice journalism class, because if you can publish in the campus outlets and have them talking about this, it can reach, yeah.
Oh, okay.
I have been interviewed by campus journalists before. I actually reached out to Spelman because they have a cosmetics program there, but I never got a kickback from them.
You'll get a kickback this fall.
Okay. But one thing I did want to note, this is an international story. I've talked to journalists from England, an African woman that was working out of England, because some of the countries, especially EU countries, do have some regulations on personal care products, but then where's the testing, where's the reporting, et cetera? And then because of the African diaspora, you have these braiding salons all across the world. And again, the workers are exposed to these chemicals day in and day out for hours at a time. And so we're also concerned about the workers too.
All right. Am I correct that China is the leading manufacturer of a lot of these?
It depends. China, India, Taiwan, most of the manufacturing of the synthetic, the Kanekalon type of products are made in that area. But that's the synthetic hair, but not the human hair or the plant-based. So.
Where are the human hair and the plant-based coming from?
Depends on where they can get the hair. The human hair, it really depends. A lot of that comes from the countries where the women have long straight hair, and then the hair is processed. And so that would be India, that would be China, and in that area also. The plant-based products, it depends. We just talked about the banana fibers. It depends on where they can harvest them. A lot of the banana fibers I'm seeing, I think, are coming from West Africa in that area. So
interesting. Okay, thanks. Okay, all right. Nichelle Smith on the Zoom has a question.
Hello there. My question is about accountability. Because this issue has been out there for quite some time. I tried to do something about it at USA Today years ago. Is there any precedent that you all are looking for being able to hold not just the companies, the manufacturers responsible for the product that they produce, but also those that sell it? And this will get us into some tricky racialized ground, of course, because I would venture to say that the majority of people selling these products that are full of lead and additives and God knows what are Asian owned, and they sell them almost exclusively in our neighborhoods.
Well, federal regulations tend to regulate at the manufacturer level, and since these products are being imported into the United States, you would have to require the factories, the manufacturers, to have some type of regulations that would control the amount of contaminants that they would test and be transparent with their data before they shipped, in products shipped. And so at the federal level, you could probably get that done. For the local sellers, which you did mention are a lot of them in our neighborhoods are Asian, there's not a whole lot of laws that I know that are moving right now. It would probably end up having to be a local type of regulation, and I haven't seen a lot of examples of that in the personal care business, where a local municipality wants to try to regulate each and every seller of this product. And then again, as I said, it really is based on testing and enforcement of any regulations that you would get set and then enforce them. Being from the federal government initially, it takes years to get those type of regulations in place.
Okay, thanks, Nichelle. All right, moving right along, Harriet Washington is with us as well, an old colleague from Rochester, New York, who's written a number of books, among them Medical Apartheid and Renaissance Men, Agents of Medical and Cultural Modernity, as well as books on environmental racism. So Harriet, are you there? Oh no, we don't see Harriet. Oh, there, I see. You have to unmute Harriet. How do I get her to unmute? Okay. Oh, could be she stepped away? Yeah, she could. Okay, all right, she could have stepped away. All right, we're going to also talk about... Yeah, Harriet. She's there, but she must have stepped away from the screen. Okay, we're going to talk about kidney health, which is another issue involving... Looks like he's trying to talk. Oh, Her picture's up there, but not her. She's not moving. Ask to unmute. Okay. All right. Well, while we're waiting for Harry to do that, we have here with us Diane Watson is here and Joe Davidson, and Diane has written a book about kidney transplants involving herself, and I wonder if she and Joe want to step in and talk about what they wrote and what they have to say about this whole issue of race and health. Oh, let's get a microphone down there if we can.
Hi, my name is pronounced Dean.
Oh, Dean, I'm sorry.
It's okay, short for Bernadine. I actually didn't come to talk today.
Oh.
No, I
But
came
since
to
you're here.
listen. I thought that Dr. Melancon,
Yeah, I don't see him, so I guess he could make it.
was going to be here, and I could ask him
Yeah.
a few questions. I'm here because, well, I don't know Dr. Melancon. How do you pronounce his name? Do you know?
Let me make sure here.
Melancon, Melancon.
Yeah,
He's the head of the kidney program.
Melancon.
Melancon at George Washington
Yes.
University. I can talk a little bit about my own story.
Yeah, just briefly.
I'm Bernadine Watson. This is my husband, Joe Davidson. I am a writer. I'm not a journalist.
Right.
And I wrote a book that was published in 2023 called Transplant. It was the story of my experience with 2 kidney transplants. One when I was about, I don't know, maybe 40 years old. The second one when I was close to 60. I have a kidney disease called focal segmental glomerular sclerosis, FSGS. I think any doctors in the room would know what that is, but it's a disease that is found in the majority sense in African American people, because I think it comes from a gene that started in Africa. I don't know all the details, but nobody in my family had kidney disease, but I ended up getting it. And my book is primarily about my own battle with kidney disease at the same time that I was battling the medical system, both to get the support that I needed during the time that I was on dialysis, and the issues with the dialysis and kidney transplant, and all of the issues with the kidney transplant waiting list, and all of the issues that come with trying to get from having kidney disease to living a healthy life. I was fortunate to have 2 donors. One was my sister, who was a living related donor, but that kidney, the disease came back in that kidney. Then I spent 5 years on dialysis and had a second transplant from an altruistic donor through what they call a kidney chain program, where my husband gave a kidney. He wasn't compatible with me, but he gave a kidney to someone so that I could get a kidney from an altruistic donor. And that was maybe 2009, which I think is 17 years or so ago. But my point is that I was able to get through the system because, one, I had support, family support. I was educated. When I came into the dialysis center, they used to say, "Oh, Miss Watson reads the New York Times," and I got, lots more attention and support from the medical community there, because they knew that I had a supportive family. One of the reasons that I was able to get on kidney transplants is because I talked to the doctors, I found out what was available, and I was able to advocate for myself. There are issues around people not being able to get transplants because they don't have telephones, they don't have support, they don't have family members doctors don't think they will take the medication. All kinds of issues like that. In fact, one of the questions I wanted to ask the doctor today was there was an article in the New York Times last year about the kidney transplant waiting list, where the list was basically called In Chaos, because people that should have been getting kidney transplants, meaning people who were on the list and needed transplants the most, were not getting them for some of the reasons that I just mentioned, and people that were recommended to get transplants that just never got on the list, because it takes a lot of support, and it takes a lot of you just have to really be on it all of the time to get yourself to be in a position to be able to get healthy, and then to be able to stay well.
Let me ask one question. Is there a racial dimension to this?
Yes, there is a racial dimension. I don't have, if a doctor's here that has the statistics, but I do, I have read that often, and, you know, I'll just talk about my own experience in my dialysis center. I was on dialysis for 5 years. I went to a dialysis center in DuPont Circle, and the whole dialysis center was black, and I was always talking about coming up, it was on the ground floor, coming up out into the light, where you would see all the white people in DuPont Circle, and all the black people were in dialysis with me. And also people that have multiple conditions. I knew people that not only had kidney disease, but they had drug addiction disease, they had diabetes and other things, and those people, you know, the doctors weren't so interested in helping them to get a kidney. The percentage of nephrologists that might pay attention to black people is another issue. Just people being able to be healthy enough to advocate for themselves, and lots of black people live in food deserts, where, you know, if you want to start there with nutrition, and then we end up on, you know, with high blood pressure, with diabetes, and these are the things that lead to kidney disease. So yes, there is a racial dimension, because black people are susceptible to these diseases because of often, you know, the way we are living in this society.
Our conditions, exactly. Dr. Benjamin wanted to add something too.
Yeah, in addition to the fact that in addition to the prevalence issue that she so clearly articulated, we also used to use a metric to decide who was worthy of renal transplantation, which was quote-unquote corrected for race. And it turns out it was structurally biased to keep black folks off the list. Wow. It wasn't intended to be that way, but that's...
What did they do?
Well, they always come up with these algorithms to decide if X, then Y. And they would do things that often structurally made false assumptions, and it ultimately resulted in less blacks on a a limited commodity being eligible and showing up lower on the list for that. You've seen a couple others. There's one where the pulse oximeter, where you measure blood oxygen level on the little clamp they put on your finger to measure oxygen level. Turns out it doesn't do real well for people of color. And there's another way that they measured lung volume. Goes back to the skin issue. The assumption that somehow our lung volume is different than whites' lung volume. Therefore, when they do your spirometer to measure your lung volume and your testing for how well you breathe, it also gives false information, which results in blacks often not getting the kind of care they need. So we have a lot of these structural things that, again, people put them in there with the idea of doing the right thing, but the evidence wasn't there when we really looked at what they did to justify.
Thank you. Okay, I see now that Harriet Washington is with us. As I introduced her earlier, she's written these books, including medical apartheid. Harriet, take it away. 3 minutes.
First of all, thank you, Dr. excuse me, Benjamin, because you brought up the point, the very point I wanted to bring up. It's so important. But I want to put a historical context into it. These algorithms, these measurements and metrics that differ by race, they're part of systemic racism, but it's important to contextualize them in history of medicine. Because in the mid-19th century, physicians promulgated the idea that Black people had diseases that only they suffered, and they had immunities disease that would not harm them, it would harm white Americans. So they believed that Black people didn't die from yellow fever or didn't die from malaria. But they also thought that Black people's own diseases were things that only targeted them. And that's why there's such tolerance to the idea that these algorithms, like the kidney one, the EGFR, is acceptable because of the assumption that Black illness is due to a different Black physiology. So, by this algorithm, EGFR, what it does is it assigns extra points to African Americans based on the same clinical picture as a white person. And the end result is to separate them from the care they need, as Dr. Benjamin pointed out so well. So people who need interventions are not going to get the interventions because racial points were added, but often these racial points had no basis in logic. They weren't based on any research. They were based on a long-standing assumption that one had to evaluate the illness of Black people differently. Black pain, that someone mentioned earlier, wonderful they brought that up. Black pain's a good example. In 2016, University of Virginia study indicated that most medical students and a good proportion of practicing doctors believe that Black people don't feel pain as acutely as white people. A very old belief. You can find this belief spelled out in the middle of the 18th century, and it's been unquestioningly adopted, incorporated in medical education. And even though we know better now, and you'll find journal articles saying this isn't true, one thing that was pointed out, I think by you, Dr. Benjamin, that's so important is that if you don't inoculate medical students against these beliefs, it's going to be hard for them to resist them when they encounter later in their training. If you don't warn them early on that you're going to hear that Black people don't feel pain like whites do, later in their career, when on a clinical floor in a lecture, if they hear that, they're not going to be equipped to argue against it. So the systemic nature of anti-Black impetus in medicine, it's really important to know the history. If you know the history and you understand how rarely any data supports it, and you understand how tenacious it becomes part of the medical education, a tacit part of their education without anyone questioning it, then you can understand it better, not as a well-intended error, but rather as the continuation of mid-19th century biases against Black people. So that's my piece.
And you said it well. Okay.
Thank you.
All right.
And your book has it all in there.
Yes, it does.
Yeah. Okay, that's great. All right, now we can open this up for a general discussion, and if people have questions for the panelists, please speak up. Okay, Rachel, I see you. Identify yourself first, and then ask the question or statement.
Hello, I'm Rachel Jones. I'm with the National Press Foundation, and I just had to sort of jump in with probably one of the most defining experiences I've ever had as a journalist was in 2018 when I was reporting on maternal mortality in Black women, women of color, for National Geographic. And I was at GW Hospital in the maternity ward, and there were two women in the room, labor and delivery room that I was in. One was Black, one was white. And the team came in, and they stood at the white woman's bedside, cooing and wiping her brow and comforting, whatever, and turned to look at the Black woman in labor, saying, physical responses. One of them, tugged the cover up, and then they all walked out. And I was standing there, and they knew who I was. And so for me, it so profoundly drove home the point that if you are not perceived as human or as much human or as someone who experiences pain or someone who is, needs that kind of interaction, it's going to affect the type or the quality of care you get throughout your life cycle. And so it's just such a chilling, yet I think as a journalist, necessary experience for me to have when I'm working with the other journalists about this issue.
Here, here. Okay. Okay. Oh, before you do, Angela Green had her hand up. She and Barbara Reynolds wrote a piece that I think I enclosed in circulating the notice of this meeting. So let's hear from Angela first, and then we go to Eric.
Good afternoon. Thank you so much for having me on today. I am the author of Legalized Extortion: How the Government Hunted Black Doctors for Treating Poor and Elderly Medicaid Patients. And my question is for you, Nicole. Nicole, in your research for your book that you wrote, did you interview any Black doctors at all for your book? And if you did, what was their impression of the NMA?
Ooh, ooh, ooh.
Sorry, that was the Cardinal thing. I forgot I'm here.
And the NMA, of course, is
the National Medical
Association, which is created, if we're thinking about the Atlanta Compromise speech in the Cotton States Expo, and during this time in the late 19th century, the NMA is created in the basement of First Congregational Church in Atlanta as the answer for Black doctors to coalesce, research, have community, have their organization as they're excluded from the AMA. I did, one of the doctors in the prologue, Dr. Body, who's the third generation Meharry graduate, who is basically holding up Hancock County, Georgia on her own, is part of the NMA. The way that she speaks about it is how key it was to her mentorship through the years. With some of the, she specifically mentions a physician who is involved with the founding of Morehouse School of Med. He is the reason for what we called Atlanta's Berlin Wall being erected when he bought a house in the Peyton Forest neighborhood of Atlanta, and the response from what's essentially the White Citizens Council is to throw up this wall. So she talks about NMA in terms of mentorship. Was there something that you were about advocating against a particular policy?
Well, I was just wondering because in my research that I did and all of the doctors that I spoke with, they had absolutely nothing good to say about the NMA and thought that they were completely useless in advocating on behalf of them. They had the same impression of the AMA, which was unfortunately linked to some of the targeting that Barbara Reynolds uncovered in her original research. So Barbara Reynolds and I are connected because Barbara Reynolds was researching and covering this story 40 years ago when it first started happening, when we first found out that the government had orchestrated attacks against Black doctors. I picked up the story in 2022, and she and I were connected that way. And so her research back then showed that the AMA was kind of playing both sides. On the one hand, they were advocating for offering merit pay to Medicaid fraud investigators to come after Black doctors and bring them down. But then on the other hand, they were reaching out to President Bush, asking him to please fire the guy who was in charge of this, whose name was Richard Cousereau. So I was just wondering, because neither one, the AMA nor the NMA, came out looking very good in the research that I did with the book that I wrote. So I just wondered what you found out and what you were dealing with.
No, I'm looking forward to reading your book. We just connected on IG about a week or so ago. No, yes. I would say the contribution of the price of exclusion delves deeper into medical education and that history and how we come to be. And to Rachel's point about what you experienced in the maternity clinic, the way that these universities in Canada were essentially putting a ban on Black medical students, which I come to research because of my great-grandfather coming from Jamaica and what were the choices after the Great War for him to go. He comes out in 1919, and they're excluded from McGill University, another university. They're fighting about this within the colonial government in Jamaica about how we've sent our best and our brightest to Canada, and now they can't finish their studies. That came out of a complaint from white women who sat on the board of trustees at the hospital about other white women in the maternity ward not wanting black attendants by their side. And so the flip side of that is that we've also seen that in the ways that black physicians in their training have had dealt with exclusionary policies, and that McGill is calling up, they're guaranteeing the Jamaican government that we're looking into this, we're going to find them a place. They're calling to Howard, they're calling to black hospitals, a lot of them run by West Indian nurses in Harlem, trying to get them what they need to complete the education, and they don't rectify this until the 80s. And so just bouncing off of Angela, this is kind of the direction I go in, and globally looking at this anti-blackness, but focusing on the physician and their opportunities. So you just made me think of that.
Eric, you had, introduce yourself and answer your question.
Sure. Hi, I'm Eric Deggans. I'm a critic at large at NPR and professor of journalism and media ethics at Washington and Lee University. And one of the things that struck me, like I interviewed Linda Villarosa, and I don't know, some of you may know her. She wrote a great book, Under the Skin, a few years ago. And she had spent a long time writing about health disparities, racial health disparities. And then when she got pregnant, she had to go through the same stuff, even though she already knew all of these issues. And so my question is to anybody who might have some advice, like even when somebody who's an expert has to go through this stuff, like what are the signs that maybe you're getting disparate treatment, and what's the advice you would have for how people of color can deal with it? And if you have any, if you want to share any stories about how you've dealt with maybe people treating you differently that could help, those of us who don't know anything, that would be great.
Okay, who wants to respond to that? Anybody online? Anybody in the...
Oh, so there's nothing. Okay.
Okay, yeah. Melanie, you can... introduce yourself and please respond.
This is just from my personal experience.
Introduce yourself first.
I spent a number of years being a caregiver for my mom, and so as she got older, we were in this cycle of home, ER, hospital, rehab, then back home. I got used to speaking up, having to speak up for my mom. I have a cousin who's a paramedic, and she would tell me, don't be afraid to yell, scream, be annoying, be irritating, ask all the questions. And that's kind of what worked, because I did notice, whenever we had to go to the ER, I would go to what I thought was the best hospital in Manhattan. It's where Beyonce had her babies and everything.
What hospital was that? What hospital was that?
Lenox Hill Hospital.
Okay.
Lenox Hill. And routinely, we would be, stuck in the back, or we were waiting longer than other people. I would just start to notice little things. And so I just became really annoying. I don't know if that helps.
That's the answer, be annoying.
Well, I'm already good at that.
Yeah, my wife just got a kidney transplant about a year ago. And what I found is that if you challenge them, eventually you'll get the answer that you need. And even asking for another opinion, another doctor on the floor or something like that, because we had, for instance, a question about antibiotics. And I'm a microbiologist, so I know a little bit about it. Plus, I worked at a clinical lab. And I couldn't get an answer about why this one and not that one. So I asked for another opinion. I said, is there someone else I can talk to? Is there another doctor or whatever? Because I was not going to allow my wife to be given this particular antibiotic if I didn't trust it was going to work, if she was going to have a bad reaction to it or whatever. So I just kept on asking questions. And when I get brushed off, that's telling me that for some reason they just don't want to answer. And I can't figure out why, especially with all the money you have to pay to go to the hospital these days. So.
You would be surprised by just speaking from the maternity ward. So I have 3, and I had all of them while I was on television. In some cases, were watching me on TV in the ward. And I've had someone ask, "Is this the father of your children?" My husband. don't know why you can't read paperwork or why you would assume, and if it's not, why that would matter.
Right.
You know, and so there are some things, and that's one thing I wanted to touch on in the book with the condition, what the physicians were going through. There's a line in there about there not being any amount of education or wealth or status that could save you from these experiences, because they're not just talking about experiences in the hospital, rather whatever. If your neighbors are throwing up the Berlin Wall to keep you out of the hospital, if you've got an overseas home and you're, in the case of Dr. Hubert Eaton, whose hospital desegregation cases are key to desegregating hospitals across the country, and most of the doctors in the book died of heart attacks, including my great-grandfather. A great amount of, so this idea of fight in the air is kind of like being more prepared for it and figuring out how much you're going to let it raise your blood pressure or not to address it. So.
Okay, thank you. We only have about 15 minutes left. Barbara Reynolds, Harriet Washington, and I can't see who else has their hands raised. So let's go to Barbara and then Harriet.
Okay, I'll try to be brief. Yeah, the reporting that I did showed how, because of high costs, this is what was said, that there was fraud in the Medicaid programs. But instead of dealing with the top firms, they went after doctors. I saw doctors who had lost their whole practice. I visit doctors in prison. I visited widows because their doctor husbands had committed suicide. It was a terrible thing. And I reported on it all through the 80s and 90s, and thank God Angela Green has taken it up. But I want to know, a recent call came out that Trump was going to get rid of Medicaid fraud. And I said, oh my God, here we go. And what can we do to raise this issue to show how the way that they are getting rid of Medicaid fraud is to get rid of the doctors? So how can we get more attention to this? Because like has already been pointed out, the algorithms can track down the doctors who are trying to treat the poor. And I don't want treating the poor be a passport to prison, and that's what it is right now. So we need to know, how can we make this issue larger and not be passed over?
The media.
You guys.
We always make everything better.
Right. Okay, Harriet Washington.
I'm so glad you raised that issue. It's a very important issue, and it's a demonization of African American physicians, okay, under color of the law. But I think one of the things we have to understand is that there would be no Medicaid or Medicare if it were not for the National Medical Association. The National Medical Association militated for these things as the AMA tried to condemn them as socialized medicine, lobbied Congress, tried to stop them. It only exists because of Black people, and it's under attack now because it's helping Black people and poor people. The problem is that breaches of the law are very easy to affect. You can make a mistake because you've simply made an error or a housekeeping error, or even a clinical error, and be charged with a criminal act.
Right.
So not all of these are people who are intending to be grifters or cheat. Some are, we have to be honest, some do indeed, but some are people who simply don't have the staff or the economic acumen to keep abreast of the law. And we have to refine the punishments and not demonize and punish doctors who simply are understaffed or don't have the resources available to rich white doctors who can hire someone to make sure they're in compliance with the law. But we have to recognize it for what it is, hostility against the program, not failings only of Black doctors. So. And it's going to be difficult with this current administration. They're successfully demonizing everything Black in medicine as DEI or affirmative action. The Supreme Court, as we know, is going right along with them. But we can counter that. As journalists, one thing I would like to see more journalists engage with is the logic behind this. When I read the Supreme Court decision, kept invoking colorblind. We want colorblind medicine. We want people practicing medicine who do not have any kind of racial animus. But if that were the case, they would eliminate legacies. People who are wealthy, whose grandfather went to Harvard, who can buy a building at Harvard or Johns Hopkins, these people, nobody questions the ease of their entry into medicine, even though if you look at the outcomes, they tend to leave with lower GPAs than people who got in by affirmative action. And we need to showcase this, go right to the root of the illogic that's being applied to demonize Black doctors. And you guys are just the people to do it.
All right. Yes.
Yeah, and just like everything else in the criminal justice system, as Harriet points out, this is using a broad stroke of the law to target particular individuals. But just remind you, there are more white people on Medicaid than there are people of color, at least Black people. And then secondly, Medicaid pays, where all the money is, it ain't in women and children. It ain't in these single adults that are being covered. It's long-term care. So it's well-to-do folks in particular, others as well, who have hidden their assets so that they're being covered under Medicaid, and it is a senior issue. That is what's driving these Medicaid costs. It is certainly this effort of this administration and the Republican Party in general trying to reduce federal spending. But all this fraud and abuse stuff is wrong. And if you don't believe in if you don't believe this is differential prosecution, remind you that the greatest grifter is the governor of Florida, who was convicted of healthcare fraud.
Oh, I didn't know that.
Okay, remind you of that.
That's right.
He ought to be in jail for what he and
and
HCA did.
Mm-hmm. Right, got it. Okay, Zara Caldwell has had a hand up too. Zara, can you introduce yourself and ask your question or make your statement?
Oh yeah, I know you guys are wrapping up, but I was responding a while ago to the question about examples, and the sister already gave an example about maternity, but I just want to raise the specter again of Black maternal health and how we have actual researchers who died of the Black maternal health who died from having children. There's two, someone just died, a midwife just recently, but I had a high risk pregnancy, and pregnancy and me just did not agree at all. I don't know why, we just weren't friends. And the high risk clinic was an eye opening. I'm Zara Caldwell. I'm the chair of ethic and gender studies at Westfield State. It's a small university in Massachusetts. I just had a new book came out. That's how I met Mr. Prince. The thing that is so interesting to me was the treatment in that high-risk clinic of folks. And who's in the clinic? Lots of immigrant folks in the clinic, Latinx folks in the clinic, obviously Black and brown folks in the clinic. Also queer folks in the clinic, because it's high risk, so people who are doing medicalized births that are extreme experiences. I had so many crazy experiences in that clinic. I used to just dread going, and I used to go every week. But it's just interesting to see how they were talking to me. One doctor said to me something like, "You have a doctorate, you should know better." But I think the one thing that we should think about for sure is it's nice to think about what you can do to advocate, but the system needs to fix, because how can you ask a question about something you don't know? So somebody offers you a medicine, if you're just a regular person, including us with degrees, how would you possibly know what protocol was the correct protocol? One more thing, I also was a Black woman who labored only at night, and they don't talk about that enough, that Black women and most women actually labor at night, mostly because of melatonin is released at night. So I would go to the doctor at 8 a.m. and be like, "I'm in labor," and they'd be like, "Oh, no, you're not." And then I would go home, and I got to the doctor, and women would understand this. I was 8 centimeters when I got to the hospital, because every time I went in, they would say, "Well, you're not," because I would stop laboring. So some of this stuff really does need to be specific to Black people and people of color. That's my comment.
Here. Okay.
If I can add something.
Yes, go right ahead. Please say your name and everything.
Yes, I'm Shubhanjana. This is my first time here. Thank you for having me. I cover immigration for Sahan Journal in Minnesota, and we only report on immigrant and BIPOC communities in our newsroom. And I think something that I was present to through this entire conversation is the biggest immigration story that came out of the state started as a health disparity story with the targeting of the Somali community in Minneapolis, and with all the fraud conversations and the mastermind being a white woman of that, and nobody knows about that. I talked about this to health journalists from across the nation at AJA when they came to Minneapolis, and they did not know that the mastermind
AJA,
of this
AJA, is what?
Asian American Journalists Association.
Okay.
And they did not know that the mastermind of this fraud case was a white woman, and the Somali community was dragged into this as to make some sort of an example. And what followed is that Black and brown families lost jobs, who worked in the childcare community, in the daycares. I have interviewed Somali Black immigrants who, by the way, have a high percentage of autism in that community. They don't have care anymore. Parents have had to, quit their jobs to care for their kids because they can't go to daycare centers because they were all shut down out of fear. And that's what brought the immigration agents to Minneapolis. And the ripple effects just followed with Latina women not feeling comfortable going to the hospital to give birth, or people just sitting at home with major chronic illnesses because ICE was in the hospital, targeting Black and brown people. So I think people often miss that strand, is that this started as a health and as a health disparity story, which then spiraled into this immigration story. So
Right.
I just wanted to shout
Well, thank you. Thank you for that. Okay, we have 5 minutes left now. Who else wants to contribute a closing thought?
Up here, Richard.
Okay, I can't.
Eric V. Tate Jr. up here.
Oh, there you are. Okay, now we see you. Go right ahead. Introduce yourself and then make your comment.
Eric V. Tate Jr., former ABC 2020 producer, now running EVT Educational Productions, Media Watch on a regular basis. And my take on years of covering this stuff is usually they target any service, whether it's medical, health related, economic related, that deals with servicing and helping Black, brown, and poor people. So correct me if I'm wrong, but they go after SNAP because they think more Black people are on there. They go after Medicaid because they think more Black people are on there. They go after Medicare when they think Medicare is helping more Black and brown people. It sounds like I'm speaking propaganda here, but I'm actually dealing with what I've seen and observed over 50 plus years being in the business. But my other takeaway from this entire health disparity situation is that because of 400 years of being in this particular milieu, we tend to be suffering from most of these health disparities, hypertension, high blood pressure, you name it, because of the political stresses that have been placed on us dealing with slavery, coming out of slavery, dealing with all those kinds of external affairs. And it gets internalized into and expressed into our genes expression. I need some of the doctors to quickly tell me if I'm misinterpreting this.
No, the concept's called weathering. And what happens is over time, because of the chronic exposures, mini aggressions, all that kind of stuff, you get really high cortisol levels. It results in inflammation, so it ultimately results in physiological changes which increase hypertension, diabetes, even mental health. So it is a well-known sociological phenomenon that ultimately results in biological change, where in many cases, people of color physiologically become 10 to 20 years older at the same age as whites because of women.
Wow.
Okay.
Okay.
Thank you. I appreciate you confirming what I thought I had researched and read about earlier. Thank you.
Okay. All right. Harriet Washington has her hand up.
First, I want to say that the concept you're mentioning, Dr. Benjamin, is laid out very well in a book entitled Weathering by Arlene Geronimus. She lays out the evidence for it, and it's very compelling. But I also want to very briefly talk about some contemporary issues. I teach bioethics at Columbia University, but I also study history of medicine at Johns Hopkins. And one of the things that I'm really concerned about is the silence about some very important developments in medicine that are harming Black people. One of them is blame the victim diagnoses. When Black people are the victims of state violence, when another Black person is murdered by police, very often the medical establishment supports the police and the state by issuing a diagnosis that puts the onus for his death on that person. Excited delirium is one of those. Excited delirium only recently been disavowed, but there was never any evidence for it. The only paper that offered evidence for this as the reason why a Black man was so strong and so violent that the police had to use a murderous voice was funded by the Taser Corporation. Such an obvious conflict of interest. It's almost laughable, right? You can't make this stuff up. Like something you read in The Onion, but it actually happened. And so only very recently did medical organizations begin saying, okay, we admit it, this is not actually true, but Black men are already dead. And then their deaths have been blamed on them, not the police. And there's also sickle cell trait has been used in the exact same way. This man died not because the police stood on his neck for 10 minutes. He died because he had sickle cell trait. This is happening a lot. It's very insidious, and there's not enough attention to it. And the other thing that I'm really concerned about is when we talk about the cost of medical treatment and medical therapies and modalities, but we often talk about the fact, well, they're too expensive for people to afford. No, it's not the cost, it's the price. Those are two different things. The price is artificially applied, and the price reflects whatever you're willing to and able to pay to stay alive, not the value of the treatment. We have cancer drugs that cost $1 million a year. The sickle cell treatment we've been discussing, genetic, these things may cost millions of dollars a year. Why? Not because they cost $1 million a year, but because they know people who have $1 million will pay it. So in my book, Deadly Monopolies, I spell all the evidence for this out, but it's something that you already know. We just don't know the details. This is something that our government could address. There is a law in place that allows the government to force people to apply a more equitable, accessible price, but we won't do it. We won't do it. We say, we can't do that because we'd be interfering with people's intellectual property, right? These companies have a right to make a living. Okay, but you did it for DirecTV. You know, you did it for things that don't affect people's health. So these are things I'd love to see more journalistic attention paid to, because obviously other people are not going to pay enough attention to it. So.
Right.
All right. Okay, it looks like we've reached the 3 o'clock moment
Ready to
here.
wrap.
Eastern Time, ready to wrap. Thank you, everybody. And you can't say you didn't hear any strong opinions or get any useful information for what I'm sure will be a flood of stories coming out of this. Thank you all. As is our practice, we will print out the chat room comments and distribute them to everybody for whom we have email addresses. And that should happen tomorrow. And if all goes well, this will be on YouTube as well, and I'll send out the link so people can watch that tomorrow. And there's plenty of food left here for those in the conference room here. But in the meantime, I hope to see you next month. Thank you all very much for stimulating conversation. And it's a wrap. Thank you. Hey.
Appreciate it. Take care. Stay safe.
Oh, Hazel just got here. Okay. All right. Thank you. Oh, wait, I forgot to mention about your book, Nicole. I forgot to mention your book being for sale.
Oh, yes.
Yeah, I want to get an autograph.
Yeah, and also they're seance. She will autograph them for you.
Thank you. Yeah, I really will, and you were making me think of some
Woo.
whitening creams. He could not get first.
Oh.
Mm. Mm. Karen, can you hear me? Karen, can you hear me? Maybe I got the wrong time.